Good afternoon to you all. Good afternoon, our esteemed participant online. Today, we are delighted to have you from all regions: Albertine, Rwenzori, Bugisu, Lango, Karamoja, Busoga, Chigezi, West Nile, and Kampala. Today, the moderator of this session, Kenneth Kuteesa by name, from Kibaale Center for Kibaale District, and I'm a nurse. I'm privileged to have our experts from different health facilities and hospitals. And to my left, they will introduce themselves one by one as we come to introduce our topic of today. Thank you.
Thank you very much. My name is Dr. Buhwa. I'm a second-year ENT resident in Makerere University.
You're welcome, doctor.
Thank you.
Thank you. I'm Ahmed Ali, third-year emergency medicine resident at Mbarara University.
Nice to meet you, doctor.
Good afternoon. I am Dr. Harry Chen. I am an emergency physician, and I am a CE Global Health Educator at Makerere University.
Nice to meet you, physician. Thank you very much for that introduction. We have our colleague online, Dr. Mwebesa Ivan, intern, Dr. at Hoima Regional Referral Hospital, will be taking us through the case presentation. And today, our topic is Epistaxis and foreign body impaction. And we all know that this is a very well emergency department case that is significantly causing anxiety and to patients and our clinician. As our language, we call it nose bleeding, but it is an acute hemorrhage from the nostrils, another cavity, and the nasopharyngeals. We have you as our participants. We expect to send in your expectations that we need to meet. And another thing, the pretest will be loaded and you will take your pretest. The session, they live in two areas such as causes of epistaxis, common foreign bodies, and the areas of impaction, emergency department assessment, investigation and management of epistaxis, ED assessment, investigation and management of foreign body impaction, complication of epistaxis and impacted foreign bodies, and we shall be demonstrating nose packing and management of choking. So we are going to post up the pretest, and we take it within 5 minutes as we go on. Dr. Mwebesa Ivan, you are delighted invited to present your case presentation from Hoima Regional Referral Hospital. Thank you very much.
Yes, thank you, Mr. Kenneth. Good afternoon to you all. Am I audible?
Yes, please, you are loud and clear.
Okay, thank you so much. Yes, as you have said, I'm Mwebesa Ivan. I'm an intern doctor at Hoima Regional Referral Hospital, and I'm glad to be part of this presentation and discussion. I would request you to kindly help me project the presentation so that we can start off.
Okay. Okay, let's respond to our pretest and expectations as the presentation loads on our screen. So doctor, you hold on for a few minutes and we see. Okay, our expectations one, we have management of congested nostrils in case of flu. We have prevalence of epistaxis by cause. Then we have blood pressure on its effect on epistaxis. These are the expectations that we are seeing. Then we have people want to know about the epistaxis in children. Then we have they want also to know about the ED assessment. We want to see about epistatic attacks among teenagers, then assessment of patients with epistaxis, then to present present practice in ENT that we shall be seeing. Then another thing is foreign body in neonates that want to be known by most of us, the participants. So others want to know about the etiology and pathophysiology. Dr. Mwebesa Ivan, I think we can present the case in the interest of time.
Okay, thank you. Again, thank you so much for this opportunity. And without further ado, we shall go into the presentation. This is a presentation actually about epistaxis. And this is a story of JV, a 160-year-old female whom we handled while at our internal medicine emergency department just a few couple of weeks ago. So it is a story of a 60-year-old female, no known chronic illness, and came in with a 2 days history of bleeding from the nose. Next slide. So she came in with, 2 days ago when she complained of developing sudden bleeding from the nose that started with small on and off bleeds. However, it worsened in the night and became continuous. The bleeding was bright red, it was too much, and it was about 2 nice cups in the description of her words. And after the bleeding and after a few times, this was followed by generalized throbbing headache. Using the pain score, it could be 7 out of 10. And then it was also followed by dizziness, and then she had tinnitus. So this is how this patient presented. And in other history, there was no history of alcohol use, there were no any chronic medications that this patient was taking. There was no any other trauma or allergies that this patient was experiencing, and prior nose infections. The next slide. And so she also never had any operations, whether ENT or facial operations. And then digging more deep into the bleeding, she had recurrent episodes of nose bleeding. And the first episode was actually at the age of 45 years. It had been on and off for some time. It came with minimal bleeding. However, it worsened over the last 3 months, and it was marked by heavy bleeding. In each month, he would have at least 3 episodes of bleeding, and each episode would last about, would end when she has lost about 1 liter of blood. And she would bleed actually for 3 days. And so this is how the condition had been worsening over the last 3 months. When we try to worry about the family history, actually, there's nobody in the family who had such symptoms. And so when we received this patient in our emergency management following the ABCD protocol, when we did the airway examination and inspection of this patient, actually she was actively bleeding by the time we received her. She had blood and clots in her mouth and nose with some mild nasal flaring, but there were no nasal masses. And then on the breathing, she was kind of tachypnic with a respiratory rate of 29 cycles per minute. She was well saturating between 96 to 97% in room air. And then more into the physical exam of the chest. The chest was symmetrical. She had vesicular breathdowns bilaterally, not resonant in no lung fields. And so the significant thing here was that bit of tachypnea. And then in the saturation, she had no edema. However, she had some mild pallor. The peripheries were warm, and the capillary refill was less than 3 seconds. The pulse was a normal volume, but markedly with a BP, which was 97 out of 65, and a pulse rate of 86 beats per minute. And so she looked anxious at the time we had this patient. She was restless. She was an elderly, and then the headache was quite too much for her. And the classical coma scale was 15 out of 15. And so, apart from these other things, there was no any other significant thing apart from the ABCD that we were talking about. And when we received this patient in our airway, as we had discussed earlier, because of the active bleeding and then the blood clots in the mouth and in the nose, we actually did a nasal and oral lavage. We lavaged this patient so that we could actually have a clear view of what is happening. And then after the lavage, actually we gave an adrenaline anterior pack. Our impression was anterior nasal bleeding at the moment when we saw him and when we did the lavage. So we did an adrenaline pack, and we did a face cold compress. However, this was later on, as we shall be discussing later on. And then in the saturation, because we noted the BPs were 97 out of 65, so we had to get 2 large IV large bore cannula. We took blood samples for grouping and cross-match, and then also to do some investigations, look at the liver function tests. And then we transfused this patient with 800 mils of whole blood, given the fact that he had an acute loss of blood, and then later on also gave a number of fluid that was 1 liter of normal saline. And because of the pain and the bleeding, we gave the tramadol to kind of help with the pain, and we can relieve the anxiety and the headache this patient was going through. And then the tranexamic acid to kind of control the bleeding, and also on antibiotics, and a reassurance for the patient, actually, that all things would be well, and trying to talk out the patient from the anxiety that she was going through. And then furthermore into the signs and symptoms, this patient had kind of a summary of everything that we're talking about. She had, as we have said, she came in with nose bleeding, which was later on followed by dizziness and headache. And then there were no prior medical the last 3 years, except some on and off paracetamol, which we would use for mild headache. And then there was no known chronic history, be it hypertension or hepatitis B or any liver chronic disease. The HIV was seronegative, and actually she had eaten just 1 day ago. Because of the bleeding, she couldn't easily eat, and so she had taken a meal 1 day ago. The events related with this presentation in this lady, actually, she had been having recurrent bleeding for these past about 15 years. That had been worsening over time. So we came up with a problem list that is in the next slide. That is in the next slide. May we? Okay. Okay. Yes. So following our initial evaluation, the primary survey, and how we try to approach the patient, try to control the bleeding, then try to stabilize the hemodynamic instability that the patient was having, we came up with an impression of a problem list. And in this patient, actually later on, we discovered this was posterior nasal bleeding, and then severe anemia with bit of hypotension that we tried to correct during our management of this patient. And as you are going to see in the next slide, if you can go to the next slide, please. Yeah, so in our follow-up with this patient, the CBC came back with the normocytic pneumochromic anemia. The HB was 6.2 grams per deciliter. The platelets were 201, and then the neutrophil count absolute was 10 to the power 10 power 9. The LFTs basically they were normal. They gave us a normal clinical picture, and we had an EN salutation. So if you could in the we have to do also an oral lavage for this patient, and then we did an abdominal. However, during the lavage that we did initially, we were able to hold on the bleeding. The patient kept on bleeding until we came in with an ENT consultation. And from the consultation, actually, this patient was taken to the ENT clinic where a face compress was done, more nozzle and the oral lavage was done again. And then she was given anesthesia to try kind of locate the exact location of the bleeding. So when the cold compression was done, it was actually able to relieve the bleeding, and the tranexamic acid was also initially given. So after the cold compress, what we realized, the bleeding actually reduced, and we were able to note out very well where the bleeding was coming out from. And we noted actually it was from the posterior aspect of the nose. And so we after the cold compress and after the tranexamic acid and after another examination by the ENT specialist, actually the recommendation was to proceed with the blood transfusion that was going on, and then also to monitor for any other observation, to observe the patient for any other bleeding if it would recur. And if it would recur, then it would necessitate to have a posterior nasal pack. However, in this patient, when we did that is the face cold compression, as well as the tranexamic acid, and then the observation, actually the bleeding stopped. And for over the next 2 days when we were with this patient, she did not have again the bleeding. And the suggestion was we should maintain this patient on antibiotics, and that was ceftriaxone and metronidazole, and then also to give a 2 days low dose tranexamic acid to help with the bleeding, given the fact of our platelet picture was looking okay, and then the anemia that had set in, and then the old lady had taken some good time without eating. So the patient was put on D10 for some 1 day so that he can resume the daily eating. And then the next slide, as we conclude with this case presentation, the next slide. Okay, so we observed this patient for 2 days within those 2 days, actually the bleeding had resolved, the headache and the dizziness had subsided, and the patient was discharged on oral hematinics and analgesics, and was to go via the ENT clinic for further follow-up and follow-up for this patient. And so this is the case that we had here at Hoima Regional Referral, so that I participated in the management. And I do believe it would be a good stepping stone for us as we discuss into this topic of epistaxis and then foreign body impaction. Thank you so much. Thank you for listening. And yeah, I saw one person ask of lidocaine and the epinephrine. Actually, it was given after the ENT consultation as we are trying to look for the bleeding areas in the nose. I think I missed out that. Thank you so much for that. Otherwise, thank you so much. Just ready to learn more from the experts. Thank you. May God bless you.
Thank you very much, Dr. Mwebesa Ivan, intern from Hoima Regional Referral Hospital. So there was also a question that Dr. Harry replied about metronidazole in this case, and I think that the participant was that has seen it in the group chat. We are going to our expert, Dr. Ahmed Ali, take us through the causes of epistaxis, IDA assessment. Okay, I beg your pardon, is Dr. Gordon Buhwa. He will take us in causes of epistaxis, IDA assessment, management, and complication of epistaxis. Please, you can send in your questions as we demonstrate, and we see the next presentation. Thank you.
Okay, thank you very much, Kenneth. Thank you very much, Dr. Mwebesa, for that case presentation. Quite interesting. And I should say well done to the team in Hoima for helping that lady. So I'm called Dr. Buhwa Gordon. I'm an ENT resident in Makerere University. And we'll just go through epistaxis in brief. This will be our outline. We'll define epistaxis, go through some brief anatomy, classify, look at the causes and risk factors, and then we go into management of epistaxis. So epistaxis is simply defined as bleeding or hemorrhage from the nose and the paranasal sinuses. You could say from the nasal cavity, nasopharynx, and paranasal sinuses as well. So hemorrhage, and I'm sure everyone has seen this happen, or maybe it happened to you or someone that you know. So then we go, just a reminder a bit about the anatomy of the nose. So the nose has a bony part and the cartilaginous part. Externally, you feel a soft part of your nose and also a hard part of your nose. You have a lateral wall and then the septum. So there are two nasal cavities, one on the left, one on the right. Sometimes when you look into the nose, you see the inferior turbinate, which is that's image in the top left corner, and you can see the septum. Sometimes, actually in our ENT clinic, sometimes we get patients referred to us because they have very large inferior turbinates, and maybe the attending doctor at that time thought it was a polyp or something like that. So those are inferior turbinates. Those are part of the lateral wall of the nose. Yeah, so the nose goes connects all the way to the nasopharynx, and also there are connections to the paranasal sinuses. We can go to the next slide. So this slide is just to illustrate the commonest site of bleeding when someone has epistaxis. So there's this area in the septum, the anterior septum of the nose, that is called Little's area. Yeah, this is where you have the commonest site of bleeding because there's a lot of blood supply there from all those arteries that we can see. The anterior ethmoidal, posterior ethmoidal, the sphenopalatine artery, the greater palatine, and you also have a branch coming from the superior labial artery, which is a branch of the facial artery. So typically you can see a child who probably has a flu and or a child who likes picking their nose. So they tend to rub this area too much as they're picking their nose, and we have bleeding from that area. So that's the commonest site of bleeding. when someone has epistaxis. The etiology is varied and can be classified into local causes as well as systemic causes. So I put there a table just to show that. And also, yeah, just for us to remind ourselves. But local causes, as you can imagine, you can have trauma. So someone is either hit in the face, and then they came in with a nosebleed. They might have some anatomical irregularities. Here you can think about the septum. Another septum might be deviated, or they might have a septal spur. That predisposes them to easily getting nosebleeds. Could be inflammation, which can come from infections and the like. You can have people who, let's say, they have allergies. Like, for example, allergic rhinitis, people tend to use topical steroids to manage the symptoms. And sometimes the side effect of those nasal drops or sprays can actually lead to a nosebleed. You can also have tumors within the nose. Systemic causes could be something to do with coagulopathy, so someone might have a bleeding disorder, might have low platelet levels, which is why it was important, like for this woman that Dr. Mwebesa presented, to just do a CBC, not just to check the HB, but also look at the level of platelets. They could have vascular malformations or high blood pressure leading to epistaxis. So there are very many other causes that are also in that table that I'm not going into details about, but at least we can appreciate all that. Can we go to the next slide? All right, so classification can actually be done in different ways, but I chose, for the purposes of this session, to classify epistaxis as anterior or posterior epistaxis. You can have primary, secondary epistaxis, etc. So for anterior epistaxis or anterior bleeds, these make up the vast majority. And we've already looked at the little area being the commonest site of bleeding. But you can also have bleeding also from the lateral wall of the nose. Typically, when someone has an anterior bleed, you have blood coming through the anterior aspect of the nose. But sometimes you do get people who, because they were bleeding, and someone told them that, you know, when you have a nosebleed, you should throw your head back, tilt your head backward. So you might also see them having blood coming from the oral cavity, the oropharynx. So that can also happen, but rarely. So mostly will come through the anterior part of the nose. Posteriorly, this makes up the minority of epistaxis, really. But yeah, you can have bleeding from the nose anteriorly, and also posteriorly. With the posterior bleeds, despite your packing of the nose anteriorly, sometimes you see there's still blood trickling into the back of the throat. So these patients will either come with, you know, there's bleeding from the nose, but maybe they're also spitting blood. If it is quite severe, the patients can actually come with vomiting with blood. So if the bleeding is too much, they end up swallowing that blood that is trickling posteriorly. And as we know, when you have a lot of blood in the stomach, it irritates the stomach, and they come in with vomiting of this blood. Can go to the next slide. So the first aid, which I'm sure we have all seen or at least experienced. I remember when I was a kid, they would tell us to tilt your head back as a way, I don't know, as a way of maybe stopping the blood from coming anteriorly. But that's not actually advisable, because someone can easily aspirate. If the bleeding is too much, they might aspirate that blood. So it's not very good. So this is really for someone at home. For example, if someone calls you and say, my child, or I'm bleeding from the nose, what do I do? So this is the first aid. So you sit up, tell them to lean forward slightly, and they pinch the fleshy part of their nose for 10 to 15 minutes. Sometimes, of course, they might be having headaches, or maybe there's a bit of pain in the nose. So it's quite important that they're actually pinching that nose tightly, and they keep their mouth open, first of all, to allow them to breathe. They need to breathe, but also if there's any blood, sometimes it can come through the mouth. So you do this for about 10 to 15 minutes or more. And usually most of those bleeds will stop, because most of them really, I would even say about 70–75% don't eventually end up in the hands of the ENT because they stop spontaneously. So 10 to 15 minutes is good. You can also use a cold packs like Dr. Mwebesa did for his patient. Some people also you can have maybe some ice cubes or that someone can suck within their mouth. That also helps, because that low temperature helps to vasoconstrict some of those vessels, and so the bleeding might be less. But I would really advise the pinching and leaning forward for 10 to 15 minutes as first aid. So after this, in case things don't go well, or there's no response, or bleeding continues, then you definitely have to send this patient to hospital. In the hospital, of course, we are all medical professionals. We know about the ABCs, like Dr. Mwebesa talked about: the airway, the breathing, circulation, disability, and exposure. So you address issues at all those levels. And then you resuscitate accordingly. If someone is really ill, hypotensive, fluids, blood transfusions are necessary. But yeah, so the patient comes to you in the hospital, you need to do that first of all. So once all those issues are addressed in the ABCs, you have to prepare to at least look at where this bleeding is coming from. So it's important to have good lighting. If you can have a headlight with you, that will aid you to just have the light on your forehead, so you don't have to hold a light in the other hand. So you have two free hands. Suction, in case the bleeding is too much, you can suction out some of the blood or clots. A nasal speculum if it's available. If not, you can always just touch the tip of the nose and try and raise it superior to be able to help you to see inside the nose. And then just have some forceps for packing the nose when you need to pack. All right, so it's important, of course, if someone is bleeding. I don't know whether you've ever experienced having a wound in the nose or bleeding from the nose, and someone is trying to put something in there. It can be quite painful. So first of all, you need to have analgesia. So the idea of lignocaine is important for that, to minimize pain as you're trying to look, as well as you're trying to pack the nose if you have to. Adrenaline is also important because it's a vasoconstrictor. Phenylephrine also is also a vasoconstrictor, so that can also be used. On the market, you have xylomethazole nose drops, which are also vasoconstrictors. So if you have access to that, you can also use those drops, xylomethazole. I think there are different brands. There's Otrivin, there's Sinarest. Just make sure you give the Otrivin. If it's in pediatrics, you get the pediatric one. If it's adult, get the adult one as well. But in most of our referral centers, or at least our health centers, we have some adrenaline somewhere. So that vial of adrenaline is 1 in 1,000. So we like to pack the nose, or at least to vasoconstrict or to decongest the nose with 1 in 100,000. And I've written there how you can make it. So you get 1 ml, and then you add 9 mils. From that, 9 mils of saline or water for injection. So you have 1 in 10,000 adrenaline. Then you get 2 mils of that 1 in 10,000 and add 18 mils of water for injection to make up to 20 mils. That will get you 1 in 100,000 adrenaline. And so you can either use a piece of gauze, or you can use a cotton ball, you soak it in that mixture, the 1 in 100,000.
You see, the other 2 people I brought.
And so you can use that to at least achieve some temporary hemostasis, or at least just achieve hemostasis initially, and also to decongest the nose, as well as provide anesthesia. So you can add some lignocaine actually to that 1 in 100,000. Yeah, so then you insert that into the nostril. So good lighting, and you're seeing, and you suction all the clothes, and you try to put that to help to decongest the nose. So you can leave that in for a few minutes, and the patient can also just pinch their nose in the meantime. You give it some time, and then you go back and have a look. Next slide. So you have different options that you can use. So if once you pack with some piece of gauze or cotton with that adrenaline, and there's no, and you still feel there's still bleeding, you can either do cautery. Here we use, I think the easiest to use would be a chemical cautery. You can use silver nitrate, a silver nitrate pencil. Silver nitrate pencil 40%. So that can be bought in the pharmacy, or if you have it in the facility, you can use that to cauterize. So again, you can also use tranexamic acid actually, help you to reduce the bleeding. Once you find the point of bleeding, for cautery, like the image is shown below, there's that bleed, I think, in the little area. So you use the tip of the silver nitrate pencil, then you apply for about 5 seconds. So as you know, with the silver nitrate pencil, you have to prime it in some water for injection or some saline, just for a few minutes. Once it's primed, then you can actually dab that area to cauterize. So it's important also, once you cauterize that area, as much as possible, try to stick to only that area, because you don't want to cauterize everywhere where there's no bleed, because then you cause some more injury. So cauterize only that area and apply, for that particular patient, if you've cauterized, you can apply some tetracycline over that area, and then they go home, and they keep applying themselves over a period of 5 to 7 days. Very important also is not to cauterize both sides of the septum. If the bleed is from the septum, you cauterize on one side only. There's a risk of perforating the nasal septum if you cauterize both sides. So very important, cauterize only one side. And then if you have to repeat, let's say if you have to repeat the cauterization later on, you have to have at least a gap in between from the first, maybe the second cautery, at least 2 weeks or more. So not less than 2 weeks. Again, because of risk of perforating the nasal septum. We can go to the next slide. There are other chemicals you could use for cautery, but I think for this session, you can just talk about the silver nitrate pencil, which is readily available. So if you've cauterized and you're still having bleed, you can do nasal packing, which we shall demonstrate later on. But here you could use gauze, which we have in our hospitals. So you impregnate the gauze with tetracycline ointment. So you get the gauze, apply your tetracycline on it, and then you pack the nose anteriorly like that, like in those images. The image on the bottom left has an anterior pack and a posterior pack. Or if you're unable to do this, you can also improvise with a glove finger, and I'll demonstrate that later on. So you get your glove that you use in the hospital, you cut off one finger, you put your gauze within that glove finger, you tie it at the top, and then you make some small holes with a syringe, with a needle, and then you can use that pack and you put it in. Yeah, we can go to the next slide. So the next slide is about posterior packing, which is shown in those 2 images, which we shall also demonstrate. So here you pack with a balloon catheter. So you just, if you suspect it's a posterior bleed, so you packed anteriorly and you still see this blood in the oropharynx, the patient is still spitting blood and vomiting. And you look inside and you still see blood trickling. Then you push in that catheter. So our usual urinary catheters that we use to catheterize someone who's going to theater, for example, it's the same one. So you just balloon it, and you just push it into the back of the throat, balloon it, then pull it slightly forward until you feel that you cannot pull it back anymore. And you strap it outside, like the way you would strap an NG tube, for example, on the side of the face. And you leave it in for about 24 to 72 hours. If you pack posteriorly, you should also pack anteriorly. So you don't just pack posteriorly and leave it, you also have to pack anteriorly, because the idea is to create some pressure within the nasopharynx, the nasal cavity, and this pressure helps you to achieve hemostasis. So you can't just pack posteriorly, you also have to pack anteriorly. So once you do pack the nose, as well as cautery, really, you also have to give some oral antibiotics and analgesics to the patient, and maybe have them come back for review in a few days. So this I just put for us to remember that there's something sometimes that you cannot handle, like we've seen from Dr. Mwebesa's example. He needed to have the ENT to review this patient. For patients who have recurrent epistaxis, and maybe you've cauterized several times, or maybe you've packed and they keep coming back, they need some specialist intervention. So you refer to the ENTs, and they can have a look and get to the bottom of the issue. Patients who have nasal masses or tumors within the nose, please also refer to the specialist. People who have posterior bleeds, especially if you've tried the posterior packing and still you're not able to achieve hemostasis, the bleeding is still there, please refer these patients to a specialist. And afterwards, so once you've helped, whether you've cauterized, whether you've packed the nose, in whatever way you've tried to help these patients to stop the bleeding, there's some things that you have to avoid, and those are the things that I've put there. No hot drinks, no sneezing or coughing, no hot showers, and as much as possible, they should not blow the nose. If they ever have the urge to blow the nose, to sneeze, they should do it with their mouth wide open. Because again, the idea of all this is to prevent whatever, let's say, if there's a clot they are helping to stop the bleed, you want that to last. Okay, so now all this, for example, hot drinks, hot showers, what do? They help, because you are taking these hot drinks, there's vasodilation within the nasal cavity, the nasopharynx, and if there was a bleeder that had constricted, now it dilates, and then the bleeding recurs. Again, also blowing the nose might force out one of those clots that was at least preventing the bleeding, and then the bleeding recurs. So you tell them to avoid that for a few days, and then you see them later on. So thank you very much for listening.
Thank you very much, Dr. Gordon, for that elaborative presentation. I think questions and answers have been replied by Dr. Harry. So let's go to expert number 2, where we shall see the common foreign bodies and areas of impaction, either assessment, investigation, management of an impacted foreign body, complication, and deposition. So Dr. Ahmed Ali, it is your turn. Thank you very much.
Thank you very much. Yes, as our brother told us that our discussion today we will discuss about foreign body impaction and joking patients, and we will concentrate in this outline. First, we will give you some introduction about the foreign bodies and what's the common foreign bodies that found in different places, in different offices of the patients, and the areas of impaction, where they mostly impact those foreign bodies. And then we will discuss about ED assessment and investigation and management and disposition. So when we are discussing about the foreign body is any object which is or substance which is foreign on to that location they found. So if the foreign body is found in other places, like it's called a foreign body when it's found in other places. So it can be classified in animate or non-animate, those which are living and moving, or those which are not living. Also, those inanimate foreign bodies classified, either it can be organic or inorganic. So, and this classification is important, and it will come according to how to approach in their management and their differential diagnosis. So, the presence of foreign body, especially in the ENT region, is the most common cause that the patients come in the emergency, or especially for ENT emergencies. Next slide. Here, the picture, what you see is the most common foreign bodies you can find, and they are, as you see, these foreign bodies are commonly found in children's. And foreign bodies in the offices, mostly the other patient groups you can find is those patients who have mental illness or psychiatric diseases. So all this you see small colorful particles can be impacted either in the nasal orifice or the ear, or can be aspirated to the trachea, or can be swallowed to the esophagus, and can go to the stomach or stuck in some place. So as you see, they are different. Some they are organics, like you see beans or nuts, they are organic foods. You see some insects, those are animated insects that can be found in the ear. Down there you see also the bottom batteries, which are very important, and we will discuss about the impact on the tissue, and also other foreign bodies with different shapes and sizes. Next. So when we're discussing about the areas of impaction of those foreign bodies, esophagus is the most common site of foreign body impaction that's found, and especially the thoracic inlet, the level of thoracic inlet, or in upper esophageal sphincter, is also a common place that foreign bodies can impact. Or it can go down and it can impact at the level of aortic arch, or even the lower esophageal sphincter. So in the ear, foreign bodies can impact between the bony and cartilaginous junction. We will see the picture where mostly they impact. And in the nose, foreign bodies mostly impact in anterior to the middle probinate or a nasal follow. So the next slide, we will see the pictures and how it looks like. As you see these pictures here, some foreign bodies found in the ear, and you see the first picture is a doctor who is trying to extract a foreign body from the ear. Those which are you can see, and you can extract by forceps or using other techniques. Here also you see some round, the blue round ball, like a foreign body inside in the ear. So it depends how you're going to extract, because sometimes you can't hold it because they don't have edicts. So it's important to use there's a balloon catheters which can go behind, and also you inflate behind the foreign body, then you extract slowly. You can see also an insect inside the ear. If it's alive, it's a very terrorizing, it's very painful to the patient, and it's recommended that you don't try to remove if the insect is alive. So it's better to first kill it. So kill the insect inside the ear, then extract it. Killing, you can use different like mineral oil. You can use isopropyl alcohol, and you can use those to suffocate the insect inside there, and once dead, you remove. Otherwise, if you try to remove when the insect is alive, it will fight for its life and will damage more in the ear or eardrum, and even the patient will become agitated, and you may even, during procedure, you may even cause eardrum or more eardrum rupture or more complications. If you see, could you take back the last picture? Down there, you can see where it can be impact the foreign body mostly, and you can see if you remove the, if you try to visualize the external auditory canal, it can impact that side. Next. When we come to the nose, we talked about the foreign bodies can impact in anteriorly to the middle turbinate, as you see there, the first image up there, and also the nasal floor. So those foreign bodies even can go, and patient can go posterior to the nasopharynx or even oropharynx, and can obstruct the airway. So if they fall behind and can go either to the esophagus swallowed by the patient or goes to the trachea and obstruct the airway. It depends the size of the patient, the size of the foreign body and the shape and where it goes at that time. So for removing those, even the nasal or ear foreign bodies which are feasible, you need again, as Dr. Gordon discussed about using some analgesics. If the nasals, you can use some vasoconstrictors to decongest the nasal mucosa to visualize the foreign body easily and also to remove it. Next. So foreign bodies, if they fall behind the nasal and goes either to the throat, it's a very danger, and asphyxia from the airway obstruction is an airway or esophageal foreign body is also a common cause which causes a death in children, especially those who are less than 2 years. Mostly those less than 2 years who are able to grasp, they are the second cause of the death of those foreign bodies which are going to the airway. So as we talked about, it depends the object size and where exactly it's loaded. If it's loaded to the upper trachea or it's inside the trachea subglottic area, if it's above the trachea and blocks the airway, the patient can come with dyspnea, drooling, agitated, and also stridor, that voice, that harsh voice they have in respiratory, and also maybe they come with cyanosis with respiratory distress. So, and sometimes those they have are worse prognosis. So if those objects goes down and to trachea, they can lodge mostly to the right bronchus, is the other, because you know the right main bronchus is wider and also more vertical to the compared to the left. So if the foreign body goes behind the focal cord, if it's not that large, it can go down and impact to the right side. Clinical features they can come for those patients who are aspirated or have a foreign body in their upper airway. They can have a Buhwa exchange. They can have cough. They can have that bad barking like cough. They are in severe distress, cyanosis, and they will have those respiratory distress. So if the foreign body is that small and goes to the main bronchus or even to the small bronchioles, it can stay there a long time and may not come. They may not have some signs or symptoms. Maybe longer weeks or days. They may not have any until they get maybe recurrent pneumonias or something else. So in the assessment, when we are in the ED assessment of those patients, again, it depends the suspect of the foreign body and how you approach those patients. Firstly, what we do is you need to do your primary assessment. Every patient who have those emergencies, you check their airway. Is the airway intact, and do they have any signs of obstruction like stridor? Do they have, are they in distress? You ask those questions.
Don't forget your time and the.
You manage accordingly. You also check the breathing. How are they breathing? Are they in respiratory distress? Do they have wheezing? or any signs of respiratory distress. You also check their circulation, stability, and also the exposure. You expose and you do examination on the suspected area. If it's the nose, ear, or throat, where the suspected foreign body is found. Next. So next thing you will do is history taking. It's important for those patients who come with a history of a foreign body ingestion or foreign body inhalation. You gather those informations, the name of the foreign body, and also how and when it's occurred. The time is important also, and how it was accidental or intentional. As we discussed with some of those patients who may have this foreign body infection is psychic patients who may put or may ingest those foreign bodies are driven, and so you inquire how they get this foreign body. Then you ask if they have past medical histories. The patient's medical history is important also if they have any pre-existing conditions in their airways, did they have any surgeries, any other, those will impact or will come to your, during your management or your disposition. Like when we discuss about disposition, those patients you find they took these foreign bodies intentionally. Like a patient, they did a surgery, I think in Mulago a year ago, they found like almost 30 needles, something in their stomach. So those patients, those psychic patients, we can send them to the disposition will be in the psychiatric department consultations. So, and physical examination, we inspect if they have any signs of trauma. Are they bleeding from the area that the foreign body is impacted? Is the foreign body, because some foreign bodies which are not round or sharp foreign bodies can injure the mucosa and the patient start bleeding, or maybe the families or the caretakers try to remove the foreign body period to the emergency department, so they may cause more mucosal damage. So you inspect, are they bleeding from there or any office that the foreign body is found. You evaluate also the airway, and if they have any obvious obstructions, like if they have the signs of obstruction, you check and their airway if they have obstruction. So the other, we talked about they are looking the nose, ear, looking even if they talk about that they have a foreign body in the nose, you also look, and ear, the ear or other sides if they have more other foreign bodies that may be missed. So next, diagnostic testing that mostly is done for those patients who have a foreign body infection. The most important diagnostic test is a chest X-ray or neck X-ray, like anterior, posterior, or lateral. And it depends again the foreign body they ingested. Some foreign bodies are radiolucent and some radio-opaque. So those who are foreign bodies which are radio-opaque will be seen on the X-ray, and is the first modality of imaging that is recommended for those who have either nasal infection, foreign body infection, or throat infections. The other imaging you can look is CT scan and also diagnostic flexible bronchoscopy. CT scan may show you some foreign bodies that we missed in X-ray, and also diagnostic flexible bronchoscopy is the best diagnostic imaging modality which can be seen either on bronchoscopy or endoscopy. You can see the foreign body itself and where it's impacted and the size and the shape, and if there's other injuries to the mucosa around the foreign body. Next. So here you see some pictures that's done and some foreign body infection. The first picture on the left corner, upper corner, is that you see a coin inside the patient's esophagus. And down the picture again, there's also endoscopy views that shows you the cone itself and how it's impacted, and the second picture is removed. Here is an important comment I want to add. to differentiate those foreign bodies which are inside in the X-ray, in the either anterior lateral X-ray, those the foreign bodies which are embedded either in the esophagus or in the trachea, there will be a small difference on the X-ray views. In the anterior posterior view or posterior anterior view of the X-ray, in the esophagus foreign body, you will see the sides. As you see the picture, you will see, the sides of that cone. Well, in the lateral view of that foreign body, you will see the edges of the coin. Is that as you see the picture in the down, like the coin in the esophagus. You see the faces of the coin when you do anterior posteriorly, if it's inside the esophagus. And laterally, when you do, you will find it in a edge side. So at that time also you look in the lateral if the trachea or air passage is anterior to that foreign body. Confirm this foreign body is not in the airway, but in the esophagus. The picture up there, as you see, coin in the trachea, is fast phase different. So in anterior posterior, you will see like the edges of the coin, and the lateral view, you will see the face of the coin. And this is the anatomical is the one plays the most important part, because the foreign body, like the coin, when it passes the airway, the focal cords is the way focal cord is made is that if the foreign body is not sitting on the focal cord, it will pass vertically, and you will see the edges in the trachea. This is important to differentiate the foreign bodies which is found in the esophagus or trachea. Next. So some foreign bodies also can stack in the upper airway, and like you see here, the stabilizer pin there found in you can see in the X-ray, lateral X-ray, and also in the endoscopy or bronchoscopy. And these are an emergence because these sharp objects, either if they are in the esophagus or in the airway, they can damage the mucosa and perforate and can cause the complications you will see like pneumonitis, they can cause pneumothorax if they are, and they can cause also mediastinitis and perforation of the esophagus if they go even down to the stomach. You find some nails can cause the perforations and they cause more risk. There, I wanted to also add, we discuss about the foreign bodies, which like the ones we discussed about the bottom batteries. They are also an emergence. We will see next slide. Let's. I think you can see the picture, the first picture X-ray very well. This is a double ring sign. Double ring sign, you can see this look like a coin, but you need to confirm, is it a coin or is it a bottom battery, which have you can see double ring, a ring inside another ring will tell you this is not a coin, and it depends how you according to management. This is an emergence and it needs to be removed urgently, because it's the batteries which if they stay there, the mucosa will cause to dissolve, and that battery inside the chemicals inside that battery will cause necrosis and bind to the mucosa, as you see the picture next there, and even can cause a perforation, necrosis, and other complications. So this is an emergence. It must be removed urgently. Well, the coin, if it's coin, it can wait like 12 to 24 hours. It's not, so it depends the foreign body type, the shapes, as we discussed about. This is and very bad, and also the down, you see the other picture, there's a bottom battery, small bottom batteries, which are inside the gut. So those are also an emergence, they need to be removed. Other emergence which needs to be removed urgently is those magnetic foreign bodies. If there are more than 2 magnetic foreign bodies inside there, they can come together and compress or the different units or different types of the gut, which can cause a fistula or can cause a perforation again. So they need to be removed urgently. Next. So when we come a management for foreign body impaction, it depends Again, the approach of the management depends on the location, the nature of the foreign body, complication that may arise from foreign body. If some foreign bodies you can see and only you can remove with a section, or even you take your forceps and you can see and you can remove it, you can extract from there. While others need a multidisciplinary team to communicate the consultant in the ENT, anesthesia team, and to take the patient to the theater that being removed with either using endoscopy or surgical intervention and the GA. So depending the foreign body you are dealing and the location is found and the size, shape, and the other complications may come, all that will depend on your management and the disposition of the patient. Next. So some of the maneuvers, some of the techniques that's mostly used in emergency to remove some foreign bodies, especially in the nose. One of the most common is the mother's kiss, which we will demonstrate in the session. Mother's kiss is done for those patients or children who have a foreign body inside the nose. We talked about those nose can be back anterior to the middle turbinate, also the floor of the nose. So these round foreign bodies which are there, you can use a mother's kiss, which the mother will see the mouth of her mouth to the baby's mouth, and you tell the baby that the mother will give you a big kiss. Then she, as you see that picture, she occludes the unaffected nostril and then gives a blow to the mouth. And we will demonstrate how it will work. The next, if the mother can't do that, and the next thing you can do the same is using a bag valve mask and applying a positive pressure ventilation. So as you see, you use a small mask which is only around the mouth, and again exclude the unaffected nostril, and you give some positive pressure on there, and you remove the foreign body. So they are same techniques, but this you use back part mask here, the mother's kiss. And next, other techniques to remove foreign body in the nasal. This is also what's called beam slave plaster, or a continuous positive pressure using a suction. A male catheter you put in the nose, unaffected nose, and you apply some positive pressure, we will help to remove the foreign body. The other picture you see a catheter, that's a balloon catheter. It's also called cat extractor. It's used to remove foreign bodies from the nose, or sometimes the ear. Especially you can use for those foreign bodies which are round and don't have edges. You can use that forceps and you can capture. So this catheter goes behind the foreign body, then you inflate with air, then you remove the foreign body easily. Next. So if the foreign body, some foreign bodies, if they go to the airway, can cause a choking. Or mostly the choking is also caused by food that impacts to your airway when you are eating that good meat you like. So the meat can be stuck either in the esophagus or in the airway. So, and sometimes those patients they may have is that sign, what's called universal choking sign. You find the patients holding their neck and fighting for life to breathe. So, and it has different, it can be partial obstruction, it can be complete obstruction. And maybe they have the signs, those you can see is either they can't speak, they are having difficulty in breathing, they are becoming in respiratory distress. If they are coughing and can speak, but they have that difficulty in breathing or choking, you don't do the other maneuvers we will show you. Next slide, you will, as you see the picture. Yes. What we do is, if they are breathing but they have some signs of wheezing, coughing, and they are making noises, you calm them and try to tell them to cough more. You encourage them to cough to clear the foreign body from the food particles from the airway or in the esophagus. If they stop talking or they are not breathing anymore, that's when we use Hamlet maneuver, and we will see in the next slide. So if the obstruction is complete and they are not breathing, that means they need that the airway is obstructed fully and they need to be helped. So those children, those are less than 1 year. If it's an infant, you will make the head down and you give them 5 back blows between their scapulas, and then you do 5 just thrusts in their sternum, and you repeat this as they need it, as they be relieved from the obstruction. Finger swabs, they are not recommended because you may, if they have a foreign body inside the pulse, or you try to swab with, you may obstruct more and you may push the foreign body or insert more. If they are more than 1 year, that's when we, or they are adults and they are conscious, but they have that complete obstruction and they are not breathing anymore, you do Hamlet maneuver. And if they stop breathing and they are unconscious now, they fell down, we don't do Hamlet maneuver. That time the patient is in cardiac arrest, we do CPR for those unconscious patients who don't have a pulse. So this demonstration pictures is how to do. This is a Hamlet maneuver. You first give the back blows for the while you make the just lean with the other hand, and you give them 5 back blows. Then you give a Hamlet maneuver or abdominal thrust. You put your one hand to the above the umbilical, and you lock with the other hand, and you do your abdominal thrusts. And we will show you how to do in the demonstration session. If you are alone, you can do yourself, as you see the other picture. You can use a chair or some place that reach your stomach. You do the same. Next. This is the one we discussed about how to do if the back thrusts and desk thrusts for the children. You do 5 back blows in the infants, and you do 5 thrusts in the sternum in those infants less than 1 year. Next. So this again, how to do the Hamlet maneuver step by step, and the picture will show you there. Next. So complications that may arise for foreign body infection, there are lots, depending again the type of the foreign body. Some foreign bodies we discussed about if they are organic foreign bodies that are beans or peas, and they stay longer in mucosal rich areas, they can swell. They may have what partial obstruction, they may cause complete obstruction due to because organics they can be swell and absorb the fluids. Some foreign bodies, if they stay longer, like those bottom batteries, can erode the mucosa and cause perforations. Some foreign bodies which are live, we discussed about which if it's found in the ears, they cause a pain, and if they are large enough, they may occlude the ear canal and can cause a deafness or muffled hearing. Some, like the now organics or even insects, can cause some swelling and also addiction. Some foreign bodies, or they can cause in the nose, they can cause epistaxis again, because they can either if during the moving the foreign body, or they can damage the arteries which were there in the nasal septum and can cause epistaxis again. Sinusitis is also an infection with sinuses. When they obstruct the sinus canal, they can cause also sinusitis. If they are inhaled and went there, they can cause bronchoaspiration, and they can cause bronchial obstructions. The other foreign bodies we discussed about is those foreign bodies which are sharp foreign bodies which can damage the mucosa, can cause perforation, then mediastinitis, can cause what baryesophageal abscess. They can cause pneumomediastinum, subcutaneous emphysema if they damage the airway, and they can cause pneumothorax. They can cause also tracheoesophageal fistula, where if they are attached there a long time and they can perforate through the esophagus or through the trachea, where they found that time, and they may be aspirated, or also they can cause asphyxia and even death. So the red flags for foreign body, we need to consider if the patient in the emergency, they have any airway compromise, such as stridor, dysphonia, drooling. These are red flags. Those patients need an urgent intervention. Otherwise, they may get a complete airway obstruction. If they have any signs of esophageal perforation, those patients who have chest pains, they have features of sepsis, or they have an emphysema, you also consider those are an emergency and they need an urgent intervention. Any history of bottom batteries, magnetic foreign bodies, or even the sharp foreign bodies are also a red flag that we needed to be seen urgently and be removed before they cause more harm. Yeah, if those are above, they are not clear what we are dealing with, always you need to seek a help for a senior, help for immediately like a different, like because these patients are not being only seen for emergency, the ENT specialists and also the anesthesia may take part for the management of these patients. Yes, again, we said foreign body insertion is a more common presentation in the emergency department, and you can see the urgency of foreign body removal. It depends entirely their location, the nature of the foreign body itself, and the patient's clinical status. Those patients who are stable have a feasible foreign body in the nose, which not a bottom batteries, or those which they can wait more than the other foreign bodies we discussed about, which can cause more harm. So some soft food policies are also common presentations. You can find those patients they may come with, but again, they have the similar suspects or clinical manifestations as a foreign body. Thank you very much. That will be the last. Any questions and discussion? We will continue.
Thank you very much, Dr. Ahmed Ali, for that collaborative presentation. And I think our participants who are virtually, you have seen that epistaxis and foreign body impaction is an emergency which can cause anxiety both to the clinician and the patient. And in a nutshell, let's go for the demonstration of nose sparking and choking management. And questions have been replied by Dr. Hari. We thank you so much. I think we are systematically moving on very well. Thank you.
Okay, there are a few themes. What about epistaxis? So maybe you could help us answer that. So what about the kind of medical diseases in epistaxis, such as coagulopathies? What about hypertension? Obviously, when you see somebody who has a bad nosebleed, oftentimes they are hypertensive. We don't know if it's the cause or the effect, but also people, a lot of questions about hereditary nosebleeds. Maybe you could let's start addressing some of those things.
Thank you very much. So, like with every other emergency, the first thing you want to do is to save the life. So you address the ABCs, but eventually you have to find the cause. So if it's hypertension, for example, you have to put the patient, either connect the patient with the physician or start them on an antihypertensive. So you have to control the blood pressure. If there are any coagulopathies, if someone was on aspirin, if someone was on rivaroxaban, things that would easily cause someone to bleed, then we have to find a remedy for that as well. For hereditary issues, There are some very rare diseases like hereditary hemorrhagic telangiectasia, where you have people who are just having predisposition because they have abnormalities in their blood vessels, the capillaries. They have a predisposition to bleeding from the nose. So it's always good that you manage the emergency, but also get to the cause of that bleed.
Yeah, the other thing is if the same, those patients we can, if you have, as we manage those patients ABC, again, you need elaborate history and to ask them, like the Dr. Gordon discussed about, are they on medicines that can cause drugs that can cause them to thin their bloods before you do any other tests? You ask more histories. Is this seasonal? This they have because the 85% of the Epistaxis is caused is idiopathic. It's not known. So you need to ask to dig here, not miss the other underlying causes if they have. So getting elaborate history how the Epistaxis started, it will help to differentiate which road after then when you do your investigations.
I have a question for Dr. Ahmed, and that is to maybe just reiterate the difference between a tracheal and an esophageal foreign body first.
So in a tracheal esophageal body, they need as the how to see the in X-ray.
Yeah.
Or
even the symptoms maybe.
Yes. So those foreign bodies, it's different when they are the foreign bodies ingested to the esophagus. The patient may can come to drooling. They may have symptoms of sensation of something stuck in their chest. They may have the chest discomfort. They may say they may can come if it's big enough. They may can come cough. Well, the others if the foreign body is in trachea, they may have a stridor. They may have coughing, which is back coughing and drooling again. So depending where the foreign body is stuck and the signs and symptoms they can come with the patients. So it's those patients who are in esophagus, mostly they don't have respiratory distress. They may breathe well, but they have this other if they have like they may have a pain. There's discomfort in the esophagus, the cough. But again, depending the foreign body and where it's stuck, sometimes they can come and they look like the same. They may come with the same symptoms. Yeah, and we discussed about how you can differentiate in different modalities like X-ray vectors we talked about.
Okay, thank you. And then I had a couple questions, Dr. Gordon, about is there anything special about pregnancy and nosebleeds in terms of treatment or in terms of causes?
So thank you very much. So in pregnancy, because of the hormonal changes that happen with pregnancy, especially rise in progesterone, which typically keeps the nose dry, the nose and other areas dry. Sometimes you have pregnant women who are prone to nasal bleeds. So yeah, that would be something that would be maybe special for the women who are pregnant. So they might be predisposed because of the effects of progesterone in the rest of the systems of the body. But again, you manage the one we've already gone through, the same steps. Yes.
Great, thank you. And I would just add that, obviously the blood pressure is a concern.
Yes.
Because we also have to be mindful of women who are pregnant having preeclampsia, right, and manifesting as a nosebleed.
Yeah.
I have another question for our two experts here, and it's from Stella. In our rural areas, when someone chokes on a fish bone, very common, in the throat, they always recommend swallowing semi-solid foods, soft pieces of food like bananas or millet roll. Do your experts recommend such first aid? And once the bone is swallowed eventually, doesn't it have an impact in the stomach organs?
All right, you want me to take that? Or?
Yeah. So, the question she said, if the fish
eat some soft things, make it go down.
Yes, there's some people who recommend, but depends if the fish bone is intact, it's like it's stuck in the mucosa. It can be inside the mucosa, and those may not help even if they take a lot of those to lubricate to allow the bone. So and may need to visit an emergency or to be removed under the endoscopical, regional endoscopy. But if the bone goes to this and like stomach, mostly they may not need to be removed to be followed up, and they may not have any much problems if it is in the stomach. But if it's esophagus, can cause a perforation. So it's like a the other sharp objects, and it's discomfort and pain. So it needs to be seen as in the emergency.
Yes, just to add to that, typically when the fish bone is stuck somewhere, the pain will persist even on swallowing. At times you get patients who think there's a fish bone stuck, but really it was either the bone just scratched a bit of the mucosa, so they feel a bit of the pain with swallowing. But there's some certain signs we look at, and you can tell whether someone really has something stuck or not. So in case you really suspect that there's a fish bone stuck somewhere in the patient's throat or in the esophagus, please send them to an ENT to review in order to confirm whether it really is there.
Right, I think that's a very good point, Dr. Gordon, that oftentimes, that fish bone going down scratches the esophagus. And so it still feels like it's there, even though it's not. And I think, as with everything in medicine, you have to weigh the pros and the cons. If somebody's got to get in a car and go 5 hours to an ENT, it's probably worth trying something like the millet and seeing how things go. If there is a fish bone and it gets into the stomach, I don't think there won't be any problem associated with it.
Okay, thank you very much, experts. At this juncture, let's go for skills demonstration on also parking and choking management.
Okay, thank you very much. Yes, I think I'll go first. I'll demonstrate the nasal parking. So, should I remain seated? All right, so I'm going to use this adult mannequin. I hope you can all visualize this. So like again, we've gone through all the first 8 steps in order to stop this nose bleed. So you get to the point where you have to pack the nose with gauze. So I'm going to demonstrate nasal packing with a gauze piece as well as with the catheter. So we start with the gauze piece. So it's important to stretch it out like this. So you don't put it in the way it was folded, the way it came. Don't put it in when it's in a square. So you want it to fit nicely in the nasal cavity, so you stretch it out like this. An important thing also is to, once you put the tetracycline on this, make sure you don't put this tip, the tip of the gauze piece. It should not be the one leading your packing. The reason being that if this gets to the back of your nose, then it easily causes some irritation and gagging, so the patient will not be comfortable. Even after you pack the nose. So make sure you don't put this tip in first. So again, have your forceps. Of course, you have to have your gloves and your gown, protective wear, your PPE. So how you pack is you make sure the tip is outside, okay? And so you start your packing in this way. So for this mannequin, this thing can go in completely. So I'll demonstrate it from the outside. So let's say this is the part that you want to go in. The tip is here. So I'm going to try and push this in the back of the nose, the floor, right? The floor of the nose. Okay. Remember, you're still holding this part outside. So you start with the floor of the nose. So once that is done, you still have your tip outside. You still have this part outside. Again, you fold this like this, and you push this other part in like that. I hope it's very clear. So again, this other part is still outside, you're still holding this. So again, you do the same thing. And you pack the rest of it in. So make sure that you try to be gentle and you push it slowly. So what you're doing is you first pack the floor of the nose, and then you keep adding layers on top of that first pack. So you try and go all the way to the back of the nose. Again, good lighting is important, so you're able to see how far you're pushing. So that's for the posterior. So in the end, you need to have your Q-tips outside here, outside the nose. So you have the rest of this inside the nose, back in that area. So you just leave a bit of it dangling outside. You can either put another piece of gauze outside. Just let me demonstrate this other one. You can use another piece of gauze outside just to dress, or to put some pressure. So you pack the nose on one side, and then you can put this gauze piece or a nose pad, and just put some strapping over there. So this stays in for 24 hours to 72 hours. Then you pull it out slowly after that period of time. That's how you pack the gauze piece. Okay, then for the catheter, this is something that we have all course in. So what you want with the catheter, because we use this for posterior packing, you need to test whether this balloon actually inflates. I don't have a syringe here with me, but again, you just inflate and make sure the balloon actually inflates and there are no leaks. Okay, so use air. So again, with this patient will not be lying down like this. The patient will at least be seated upright. So you're pushing the catheter along the floor of the nose. Again, this can go in completely, so we show it on the outside. So you're going all the way to the back of the throat. So of course, when it hits the back of the throat, the patient might gag because it's irritating. So what we usually do is once you have a balloon at this point, this is where the balloon is. This part, this tip here can actually be cut. So we cut just right after where the balloon is. Okay, so you cut that part so that you shorten the catheter itself, so that it does not irritate again the back of the throat, so that it's comfortable for the patient. So once you cut that, then you push this. Of course, you can either use some KY jelly or tetracycline to give you some lubrication along the floor of the nose to the back. So once the patient feels the catheter in the back of the nose, you pull it back. Once you deflate at the back of their throat, you inflate the balloon, okay, and then you pull it slightly backwards. So the back of the nose has an opening again, the choana. So once the balloon is inflated, as you're pulling back, it will get stuck just at the choana there. So you'll be able to feel that you cannot pull it back anymore. So the remaining piece, the remaining part of the catheter is outside, and then you strap it here to the patient's face. So you can put it there. Again, you pull it as tightly as you can so that you apply that pressure that you want, that tamponade on the bleed. So once you do the posterior packing, posterior nasal packing, you also have to do the anterior pack. So I showed you how to do the anterior pack with the gauze. So you do the same. Once the catheter is out and someone has, maybe someone is holding it or it's strapped outside here, you pack the anterior part of the nose as well. So when you do a posterior pack, you have to put an anterior pack. Okay? If you do an anterior pack, you don't have to do a posterior pack. Then maybe one other thing we could use to improvise, in case maybe you're not very comfortable with this, I can't push in the gauze properly, or the patient looks at the gauze, it's too long and they're scared. You get a glove finger. So this is your glove, okay? So you pick one of these fingers, so you just cut it here, okay? So the assumption is you've cut it there. So where you cut, you get that glove, okay? And then you can place this glove actually within that finger. So let me imagine this is the finger itself, the entire glove. Imagine it's the finger. So you push it inside. Okay, so once the gauze is all inside, then you tie the top. You tie the top of that glove finger. So you can either use a suture just switch it so that it's tight, or you can just tie it just like that. You find ways of tying it. So once it's tied, you have to make holes on that glove. So you either get a needle from the syringe and just poke small holes, okay, everywhere. All right, and then you apply some tetracycline on that glove finger, and you can usually push it inside the nose actually. So that can also help as a way of packing the nose anteriorly. So you push it in, make sure there's just a small piece outside, or at least it's visible enough for you to be able to pull it out after 24 hours to 72 hours. So again, once you pack, remember antibiotics, penicillins preferably, and then analgesia as well for that time that the pack is in, because the pack itself is a foreign body and can predispose to infections. So that's it about the nasal packing, unless you have any particular questions. I'll hand over to you.
There is a question about how much air do you put in the balloon, and do you need two Foleys, or is one usually enough?
No, that's a very good question actually. So one Foley is usually enough. 1 Foley is enough. So you can use between 5 to 10 mL of air. I think that will be sufficient. And sometimes when you put and you pull it and you feel that it's still coming out, you can push it back, add some more air, and then pull it back till when you feel it's not coming out. It's really stuck in the corner and you can pull it outside. The other thing is, instead of using water, which you typically use to balloon this catheter, it's probably better to use air, because if this pack stays in the patient's nose for 24 hours, they have to sleep with it. Imagine that this balloon had some fault, and so the balloon bursts at night. God forbid it happens to you, but if it bursts, the patient might either aspirate, and that will give you other complications. So if you can, please balloon with air as much as possible to avoid that risk.
Great. And the only other thing I would add is, I've done a lot of these packs in my life. It is not a comfortable procedure, and it's not comfortable for the patients. In some ways, it has to be a little uncomfortable to put enough pressure to tap it on the bleeding.
Thank you very much. So again, make sure the patient is comfortable with anesthesia. You try to reassure them during the entire process so that they are as comfortable as possible when you're doing the nasal packing.
Yeah, thank you very much, Dr. Gordon. I think there's been an expound demonstration. This is Dr. Ali on choking management.
So we discussed about those patients who are less than 1 year old, an infant who is choking. First, how to do the fast thrusts, chest thrusts, and back blows. To do 5 back blows, first what you do, you take the jab in one hand, holding the cheek, and the jab facing down his face. So you give in your heel of the other hand, you give 5 back blows between his scapula, shoulders. So you give 5 back blows into each second. Then again you give the part external thrust for 5. If he relieves, that's good and well. Otherwise, you repeat again the cycle, and you do again the cycle, and you repeat 5 back blows, 4, 5. Then you do abdominal thrusts. 5 abdominal thrusts. That's how to do the 5 back blows and 5. Just thrusts for the infants less than 1 year, for the children less than 1 year. The other maneuver, Dr. Hari will take us through how to do a mother's kiss. In adults, as you seen, let's use this, and also, and even the children's above than 1 year, depending your height and the height of the patient, you come behind the patient. And if they are feeling or choking, but still they are conscious and they are not breathing, you help them. Like they lean forward and you help the other hand in their chest. As you help, you give again back follows. So if you give that particular, then for the according to their height, and like now this child is small, I may kneel and you put one of your fingers above their bellies, and you hold the other. You rub your hand up behind the patient. Then you give abdominal thrust. Now this is small. So the way you were seeing the things. So you put your hand. You give abdominal thrusts. 5 abdominal thrusts again and again. If they don't leave, you repeat the cycle. So we said we don't put the finger swabs for the infants. We don't, because that may increase the risk of pushing foreign body further in. I welcome Dr. Hari to show us how to do the mother's kiss to remove foreign body in the nasal cavity.
So I think in the interest of equity, I'm going to do the father's kiss, right? Instead of the mother's kiss. But really what you do is, the goal is to really reproduce mouth to mouth respirations, but instead of closing both nostrils in a kid, you only got to close the nostril that is free and clear. So you're going to leave the nostril open that has the ground nut in it, that has the bead in it. And then when you go, so you'll instruct the mother or the father or the parent to basically occlude the nostril that is clear, and then go and kiss their child and blow. And what happens is you create enough pressure when you blow that it pops out the bead or the ground nut. So it works really well with round things that are hard, and that can create a seal. And in some studies it works, and they could try repeat it 2 or 3 times. And the reason you ask the mother to do it, because if I tried to go near a kid in an emergency department, the kid would just go ballistic, right? So the mother can get close enough to really apply consistent pressure and actually the amount of pressure they need to clear. Now, if the mother isn't around or father, and they're uncomfortable, you can really reproduce the same thing. And this is not the appropriate size mask, but you take a bag valve mask, especially one of the little ones, for really like neonates that's just round. And essentially you're going to do the same thing. You're going to have somebody hold one of the nostrils, again, the clear nostril, and then you're going to put the bag just over the mouth, right? And then you're going to give a few puffs. So the mask goes just over the mouth. The unaffected nostril is occluded. You apply positive pressure, and if you're lucky, the ground nut or the bead will pop out. And it's certainly worth a try before trying to dig in there, because what oftentimes happens is once you start digging around, things get swollen, gets harder, you get bleeding, and ultimately it becomes more complicated. So worth a try in the beginning.
Thank you very much, Dr. Hari.
Okay, thank you very much for that skill demonstration. I'd like to take this opportunity to thank Dr. Ahmed Ali, Dr. Gordon Buhwa, and Dr. Mwebesa Ivan and Dr. Hari for the nice presentation on epistaxis and foreign body impaction. I think the questions and answers have been replied very well. And earlier we said this is an emergency department case. that causes a lot of anxiety to our patients and the community at large. And I would like to thank also SEED Global for this tentative capacity building to improve the continuum of care up down to the grassroots, and Ministry of Health for giving us this opportunity, and the IT team for forecasting us to the entire world. Thank you very much. Back to our post-test and closing remarks from our panelists or our experts about our topic of today, Epistaxis and Foreign Body Impaction. Thank you very much. We shall start with Dr. Gordon.
Yes. Yeah. Thank you very much, Kenneth. So I hope the participants found the session interesting and informative. Again, I think there were questions in the chat that Dr. Chen was answering. This is a very good initiative. Learning never stops. So again, you can always look up some things. I think maybe my take home for today for Epistaxis is do your ABCs, try and go stepwise in terms of management. So start with medical, and then and try and cauterize, you can try and park. And then if to keep in mind like the red flags or things that will show you that this is not just a one-time thing. And I'll be able to manage this on my own, but to know when to refer the patient to the ENT specialist. So I hope it was informative, and thank you very much for having us.
Thank you very much, Dr. Ali.
Thank you very much. Yes, it was a very exciting session, and thank you, team, and the audience. And again, we were trying to cover a very large topic in a short time. We tried to give you the important things for your main clinical experience and clinical in the work in the hospital. So as Dr. Gordon told us, please always know which patients you need to consult a senior consultant. And if you ever try these maneuvers that we show here to extract foreign bodies, if you fail more than and you think it's difficult to extract, don't lose the time to repeat it more. Consult a senior consultant. Maybe they need to, like an ENT consultant, emergency team, or also anesthesia. Some patients, like also we need to consider those all are very agitative and painful. So always let's consider like the pain relief modalities, non-pharmacologically and pharmacological also, for patients come to. So thank you very much. I think it was a very productive one.
Thank you very much, Doctor. Welcome, our physician.
Yeah. So I want to thank everybody for joining us today. I especially want to thank my colleagues on the panel because they provided really succinct expert advice on what you can do out in your emergency unit to try to deal with these very common complaints. I certainly think that many of the things that were suggested are certainly worth a try, but understanding that sometimes they don't work. But many, if not most of the time, you can actually succeed stopping a nosebleed, getting a nasal foreign body out without having to really put family and or a child or an individual patient to the trouble of having to find specialists that may be hours and hours away. So again, thank you for joining us, and we all should never stop learning. And should continue to advance our practice.
Okay, thank you very much, Dr. Hari. So I think the post-test is done. We need to go through the polls and see how our esteemed participants attempted these questions, the quiz that was given. And
it.
Okay. Okay, this is our 55th post-test pause. And question number 1 was, in choking infants, what is the recommended technique for receiving an airway obstruction? So, Dr. Ali, question number 1 was in a choking infant, what is the recommended technique for receiving an airway obstruction?
Yes, so we gave now the answer, it was answer A, that the patients, an infant who is less than 1 year, like the one we demonstrated here, you give her 5 back fellows, then follow it by just thrusts, 5 test thrusts.
Yeah, it was well elaborated, and our participant answered it at 83%, which was very okay. Then question number 2 was, what is the initial step in managing an active anterior nosebleed in the emergency department?
Yes,
Dr. Gordon.
Yeah, so again, 4 options given there. The first one was immediate cauterization. The other one was application of a topical vasoconstrictor, nasal packing, and elevating the patient's legs. I hope no one chose D, but the answer there should have been application of a topical vasoconstrictor.
Okay, I think you have learned a lot from this session, and 20%, I think, Dr. the one that passed that question, I think they have gained from the demonstration that you have had here. Thank you. Then the third quiz was, what method is generally contraindicated for removing a live insect from the ear canal? Yes, Dr. Ali.
Yes, again, the third question, we gave 4 choices. One was irrigation with a warm water, use of mineral oil or olive drops, grasping with the forceps, and inserting a cotton swabs. So which one is contraindicating? And the question, the answer is C, grasping with the forceps. And we talked about that before you grasp, kill faster, otherwise you may cause more damage to the eardrum, and it's very painful. So suffocate neither the mineral oil or the other answer. So the answer is C.
Okay, thank you very much. I think also they gained from the presentation, because we see a 30% managed to respond it correctly. Then lastly, it was in a patient presenting with epistaxis and signs of shock, what is the immediate priority? Yes,
Signs of shock. Again, 4 options: applying the nasal pack, initiating anticoagulant therapy, ordering a blood transfusion, and administering IV fluids. And so the answer was administering IV fluids, because this patient was in shock. And you have to correct the circulation issues before you address anything else.
Okay, thank you very much. And I thank you all for participating virtually to this session. And gaining knowledge is a pillar in this world of living. So capacity building is ongoing, and we thank Seed Global for this initiative of making us to explore more knowledge from different experts like Dr. Ali, Dr. Gordon, and Dr. Harry. Thank you very much. I think it is time to close, and virtual participant, thanks for that time, and thanks for the resilient amid these any network challenges that you have attended these sessions. Thank you very much, and nice evening.
Bye.